Do you prefer Dr. Groot or Gary or?
Gary.
Okay, Gary. Well, we've got everything going. So Gary, thank you very much for coming on. It's very nice to meet you.
Nice to meet you.
I was preparing for this last night, and I had to write quite a bit of notes just to get everything that is in your resume, I guess you could call it, down. There's quite a bit of information on your page on the USask website there. I was very curious. You've been involved in so much in medicine. Did you always want to be an educator and get into medicine? And
It's an interesting question. I didn't go into medicine with a goal to be an educator.
no,
That evolved and is part of the territory, if you will. But it wasn't the thing that brought me into medicine in the first place. That just sort of came later, and then later yet came an interest in research and an interest in educating or training at a graduate level. So once I was practicing surgery, part of that job, and at least in Saskatchewan, for me was training surgical residents and undergraduate trainees. But it moved into something different when I started doing research.
how long did you know you wanted to be a surgeon for?
So there's a story there.
Okay,
I
yeah.
hope we have a little bit of time. When I was,
We've got lots
I
of
still
time.
remember well when I was in high school, the same stage as my youngest children are just finishing up now, and I remember going through a process where I said, well, what career, what job do I want to do? And I didn't start by saying what job. I started by saying, what do I know about myself, and how would that fit with various jobs? And so there's a few things about me that I knew. One was that I was an introvert, strong introvert. Another is that I liked sort of depth of relationship rather than superficiality. And another is that lifelong learning was something that I wanted to have as part of of whatever career. And then I came up with a short list of what that might result in, and one of them was medicine. I got lucky and got in.
Yeah, well, it takes quite a while to get there, so congratulations.
It did take a little while.
Yeah. And what? So oncology is your specialty?
So I'm a general surgical oncologist.
Okay.
So I do cancer surgery. Yeah.
And what pointed in that direction as opposed to anything else?
Again, there's a story there. I started my career actually in Africa.
Oh, wow.
When I first finished. Back in those days, we did a 1-year internship, and at the end of my internship, I had the option of going into family practice or to go into a specialty, or I chose something different. I chose to go overseas to Africa, and I landed and worked in a community about the size of Saskatoon, and servicing an area about half the size of Saskatchewan.
Wow.
I was one of 2 physicians.
Wow.
And it was quite an experience. I was 24 years old.
I imagine, yeah.
And when I was there, I already knew I had an interest in surgery, but I fell in love with surgery. And so after the end of the 3 years that I was there, I initially was planning on returning, but my wife at the time was not well, so returning wasn't an option. And I decided to do surgical training here, and then at the end of that decided to do subspecialize in cancer. And the reason for that came as I was doing my surgery training. I realized that I like surgery. I like it a lot. But I felt like I was having to give up something in surgery. And the thing I was giving up was the deeper relationship with people. And I found that again with cancer surgery, because you develop quite significant and important relationships with not every person you deal with, but many of them. And so I got to grab the thing that I thought I was going to lose. I got to keep it.
Wow, that's great. Where in Africa did you?
At the time it was Zaire. Now it's called the Democratic Republic of Congo.
Oh yes, yeah. What was it like just living over there?
It was incredibly formative. I can say that. It was challenging and at the same time rewarding. As you might imagine, I was 24 when I went there. So I had this I was going as I was going to save the world, so to speak, and realized that I had as much to learn as I had to offer, if not more. And so that was humbling, and it was very formative. And I still learn things from the time I was there. They still surface. There's things I have to learn. So it was very, very significant for me.
A bit of a wake-up call, maybe, going over?
A wake-up call, but also a maturity. Like I learned about privilege before privilege was a thing that was talked about in mainstream society. I learned about the strengths that come from the people I was working with, and I continue to learn from them. I still have connections back in Congo.
And was there a particular reason that you chose the Congo?
I was attending a Mennonite church, and that's where they had some work and a need. I wasn't supposed to land in the place I did. I was supposed to be going to a larger center as a newly minted physician, and then at the last minute there was a need in this smaller community, and so that's where I ended up. I used to, back in those days, this was before I did surgical training. I would operate every morning, do my own anesthetic, and then the surgery. And then while I was operating, my nurse had a team of nurses that would see 1,000 patients or so. And
each day?
Yeah.
Oh my goodness.
And in the afternoon, I would see the people that they didn't know how to manage. And then before I went home, I would quickly round and make sure everybody was okay.
Wow.
So it was a pretty intense couple of years.
I imagine. And you said this was half the area of Saskatchewan, or half the population?
Half the area and population.
Oh wow! So you had your work cut out for you.
Yes, I did.
Yeah. And sorry, how long did you spend there?
2 years.
2 years.
Yeah.
Would you do it again?
I would do it again, but I would do it differently. I think that with what I know today, I would go at the request of somebody who wanted to learn something, and I would insist on, in my time with them, would elevate them and the care that they do, rather than have any focus on me as a provider.
Right.
If that makes any sense to
No,
you.
it does, yeah.
Providing capacity as opposed to... Often, I think, well-meaning people from the West go to places like that and actually undermine the people that are there just because they have resources and capacity that they don't leave behind, and so they leave the perception that the white guy from the U.S. or Canada is really the person you want to go see, rather than lift up the people that are there.
Right.
And they're just as capable and just as smart as any of us. They just sometimes don't have the same resources.
Yeah. I've heard that theme a few times. Kind of like bring a man a fish or teach him how to fish.
Correct.
Right? So yeah.
So I would never go back and fish. I would go back and teach.
Very nice. And how did you end up in Saskatchewan with all of your positions? Are you from here, or?
I was born in Regina, but I grew up in the southern U.S. in Florida, Alabama, Tennessee.
Oh wow!
We came back when I was in high school, and so I grew up. My recollection of growing up is actually in a small town in high school, and coming to Saskatoon felt big. And then I went overseas. I did some training in Belgium first before I went to Africa. And so coming back here felt a little bit like home. And after I did my subspecialty training in Winnipeg, I came back and I've never left. So just enjoyed it.
Yeah. So you've been around a lot. Have you noticed any particular differences in just the people, especially in all the places you've been?
So I said I continue to learn. I think that's one of the things even today I continue to learn. There was a point in time when I went back and did a PhD late in my career and then took on the research side of things. And when I did that, I started by recognizing in myself that I wasn't doing as good a job with my Indigenous patients as I would have liked. So I wanted to understand what that was about, and set about trying to do that. And I connected with a number of elders and Indigenous knowledge keepers who said, advised me to just take time first, get to know some people. And in the process of doing that, I came to realize that a lot of what I learned, I told you earlier on that I learned from the people that I was in Africa with. A lot of what I learned was about a different worldview, if you will, from the one I grew up with. And I found that again with the Indigenous communities here. It's not exactly the same, but it's much more the same than not. And so, yeah, I continue to learn about things like that from the people I work with.
I noticed in I apologize, I can't remember if it was research you had already done or ongoing research, but you're working with the Métis Nation of Saskatchewan to work on looking at how to provide better health outcomes.
Yeah. So one of the many projects that I have now, when I first started doing research, and for me that started only about coming on 8 years, so a little over 7 years. When I first started, I wanted to understand my own weaknesses in terms of working with my Indigenous patients, and to do that, I worked with an Indigenous scholar who was a nurse, and we went out together and did interviews with cancer patients to understand their journey and how that intersected with what I was accustomed to. That in turn has led to multiple projects that I've done, research projects with Indigenous communities and Indigenous organizations. And at this point, I prefer that they come and say, I have an issue that we'd like to work with you to work with us, rather than coming from me. And it feels a lot more like the same thing I was talking about with how I would go back to Africa. And so, yes, I'm currently doing a project with Métis Nation Saskatchewan, looking at how cultural revitalization in their communities can be done as a way to promote and prevent cancer. So if you're living well and you're able to draw on the strengths of your culture, the assumption is that will reduce cancer by increasing strong living and good living. And how do they successfully revitalize their culture, which they're in the process of doing more all the time.
And in the process of doing more all the time?
They are in the process of revitalizing their culture.
Oh, okay.
And so my job working with them is just to help them tell their story.
I see.
It's as simple as that.
Yeah. It seems like a very noble project, and it'll be quite...
It's fun.
Yeah.
I got to go on a traditional bison hunt, and my team got to go on a dog sledding cultural event recently. And so, yeah, and like I said, I still continue to learn about the strengths of their culture and how they can revitalize.
Yeah. Is there anything that you try to implement from their culture specifically that you can take into?
I think the most important thing for me is just that the relational side of being, right? So, for example, I'm about to embark on a different research project unrelated to Indigenous communities directly, to do with post-COVID condition or long COVID. And the process, without going into details, the process of working with some of the support people we have has been a little bit challenging to get started. Largely, I think, because there's the work that the organization, the Saskatchewan Health Authority, is doing, and then there's the research work that we're doing, and we're trying to have them understand that yes, that's important, but the research is also important for a different reason. And in order to do that, I'm going to actually borrow from what I've learned from my Indigenous work and my Indigenous colleagues, and do a talking circle as a way to have that communication. It takes longer. It starts by inviting people to say, who are you and why are you here doing this in the first place? A little bit like you did with me. And then from there we'll get to the next part, is like, how are we going to work together? Right. Instead of just jumping in and having a half-hour meeting and let's get to the point, bang, 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 bang. Yeah. So that way of building relationship and finding a way to be in relationship is a very, my experience is it's very, very Indigenous, but it's something that we could all learn from.
Yeah. No, I think that's great. And I think that a lot of people, unfortunately, are missing that with particularly their general care practitioners. There's a lot of people that I think find that just from anecdotally hearing that their doctors go in and it is just quick, and that getting to know people and having that relationship with them and trying to understand a little bit more what the needs are and not just how to solve a problem is really important. So it's very, very interesting.
Can't agree more.
Yeah. It's like I said before we started the podcast too, I work in the financial service industry, and I was reading the other day that most clients leave their financial advisors if the financial advisor is a lot more likely to lose a client if they don't know about an upcoming life transition. And so it's just, if they don't have a relationship essentially with their client, they're more likely to go somewhere else. So
yeah, I think I won't speak for everybody. I'll speak only for myself. But I think during the pandemic, a lot of people found it hard. A lot of people. And I think coming out of the pandemic, we all have the opportunity to pause a little bit and not just rush back to doing and being the way we always have, but to think, what are the parts of life that I want to keep, and what are the parts that I maybe can let go of? And for me, it's refocusing a bit on the relationship side. The people that I've known for a long time but don't live in Saskatoon, during the pandemic, I actually got to connect with them more.
Oh yeah.
And so I've been reaching out to all of them, say, I don't want to lose that. That was pretty neat to be able to every few months just have a Zoom call, and we didn't do that before. So the pandemic has given us some positive things. At the same time, it's been very hard.
Yeah. No, I would completely agree. One of the last guests I had on, we were talking about that as well, and we were talking particularly from a trauma aspect for people within families, so it's a little bit different, but just this idea that people just need love and attention. At the end of the day, everybody wants to be heard and have a connection and have those relationships like you're talking about, and have frequent contact with the people that you care about. So yeah, I agree. I think that was a really good lesson to the pandemic, especially with like Zoom took off and now everybody's conference calling, and I think it's opened people's eyes to the fact that they can reach out to people that aren't in their city or aren't around them. So, and you mentioned long COVID. Can you tell me more about that? I saw it in your research areas, and I've heard that term before, but I don't really know anything about it.
So a percentage of people who get COVID go on to develop ongoing symptoms from it, and they tend to be in clusters. So there can be overlap with clusters, but they tend to have things like brain fog, not being able to concentrate, shortness of breath that's ongoing, and just fatigue, not being able. Some people are so badly affected that they only can get up and do things a few hours a day.
Oh wow!
And it really has significant impact. Fortunately, the majority of people by the end of a year, this has improved, but there's still a lot that we don't know about long COVID. And what causes it, and how to best support people who have long COVID. As of right now that I'm aware of, there's no specific treatment for long COVID. If you get it, it's a matter of supportive care until you are able to manage better or your symptoms improve. It's devastating, and when you think about the impact of how many people have had COVID, even if you say 10% of people will develop long COVID to some degree, that's a large number of people. So there's actually a lot of work. I feel very fortunate. I'm doing a particular small project in Saskatchewan around the mental health aspects of long COVID. That's the one I was just talking about earlier, but I'm also co-leading the development of a pathway for long COVID in the province with the health authority. And I'm part of a research network across Canada that's going to be trying to understand and develop pathways and treatments for people with long COVID. So.
Is there much headway being made in that direction right now?
Yeah, it's moving fast. It's like I don't know to what extent you were paying attention to the research that happened with COVID in general. It was like research on steroids. Things moved very quickly.
Oh wow!
As people around the world collaborated in a different way to try and understand it. And the same thing's, I think, going to happen with long COVID. Okay. We're getting a lot better collaboration. Normally, it takes years for research findings to get implemented into practice, and I think we'll see a difference with this. It'll happen much quicker. Not quick enough for the people who are suffering right now, but still much quicker than has been historic.
Yeah. Well, I think COVID definitely put quite a bit of angst and fear in people. I think it's still the top of mind for a lot of people, and it's a very recent and not quite yet over issue, I guess. So I would imagine that there's still a lot of eyes on that.
Yeah.
Yeah. You're also an epidemiologist, is that correct?
It's a part of my training was to do epidemiology. I actually, most of my research focus is pretty qualitative, and I sort of try and understand why systems work and how they work and for whom they work, rather than necessarily playing with the big data. That's what my colleagues do more of that sort of thing.
Yeah. Did they have a bit of a heyday with all the COVID data coming in?
There's so much data; it's sometimes hard to know how to even approach all of it. There's more to be learned than there is people to do the learning. It seems like at times. And I think one of the things that when it comes to learning, one of the things I have taught my children, and I try and teach my residents as well, is that what I know today is what I think I know. And the only thing I know for certain is that I will think differently tomorrow. There's so much that's changed even in my lifetime that I think it's naive to think we know all the right answers. We know just what we think we know today.
That's really refreshing to hear, to be completely honest with you, because it seems like throughout the last few years I've been hearing a lot of people just saying like, no, we know this is the answer, and we know. And maybe that's just my anecdote and my personal experience, but it seems like there was a lot of people, even like people that aren't scientists or researchers or politicians, everybody became a doctor, and they're like, no, we know how to fix this, we know what's going on. So
yeah, when I approach my patients, I can tell you that most of the time I just say, this is what I advise based on this evidence. It's the best that I have, and it's all that we have right now. But that doesn't mean that 5 years from now I wouldn't be giving you a different piece of advice. Right. And so we have to go with what we know today, but that changes. I can tell you, I don't know how much time we have, but
we got lots of time. Yeah.
Okay, 10 years ago, or maybe 15, when I would see somebody with melanoma, it's a kind of skin cancer.
Okay.
And often the melanomas would come quite late and they'd be widespread. And in my mind, I'd be going like, yeah, you're not going to be here in 3 months.
Right.
And now I see that same person, and there's drugs on the market. They're immune modulating drugs rather than chemo, and those same people, 30% of them are alive.
Wow.
and well 10 years later. It's been completely changed the landscape, and now those similar kind of agents, that family of immunotherapies being applied to certain kinds of breast cancer that traditionally did very, very poorly, to advanced skin cancers, to lung cancer. And so that wasn't there 10 years ago. Those people they passed on, and now they have hope, so.
Isn't that incredible?
I think it is. Yeah,
I think so too. And the technology is it's incredible how the pace that it moves at, and the increasing pace that it moves at. And again, I can't remember where I read this, whether it was a journal article or just a magazine article maybe, but I'd heard that a lot of people go into getting cancer now and are not nearly as worried about it, I guess, depending on the kind of cancer they've been diagnosed with. But I think a lot of people are gaining quite a bit more confidence in the medical system and its ability to treat them because of stories like that.
Yeah, and that's one of the, depending on how much time and effort you put into looking at what is cancer. Cancer is not one thing. I mean, we define cancer as an abnormal group of cells that are capable of spreading, but I mean, a thyroid cancer is not the same as a breast cancer, as a pancreatic cancer. And even within breast cancer, it isn't one cancer. It might look similar under the microscope, but in fact, there's actually probably at least 4 or 5 different cancers that are called breast cancer. The same is true for other cancers, including thyroid cancer. So almost every tumor that I deal with, it's much more complex than it first looks like.
Oh, wow. And How do you go about figuring that out? Like from just like there being symptoms and then getting down the line
Well,
of knowing.
So let me go back to the thing that's a lot of people are aware of because it's so common, and that's breast cancer. The way it started is breast cancer was breast cancer, and then we came to realize that there were some women that did very poorly, and then there were characteristics of that cancer that were similar in that group of people. And then some scientists discovered something called a HER2 receptor. So there's a group of about 10% of women who are HER2 positive. And that's a genetic marker that rather than the way it looks under the microscope. And those people did very poor until they discovered a drug that bound to that receptor. And then with that chemo agent or monoclonal antibody, those women now do as well as anybody else. So those kind of small incremental steps come from observations that people make. This isn't fitting quite. Same was true for head and neck tumors. When I first started in practice, generally speaking, head and neck tumors did very, very poorly. And then we realized there was a subset of people that were a little bit younger, maybe didn't fit. They weren't heavy drinkers, heavy smokers. And over time, they came to realize that these were caused from HPV virus.
Oh, wow.
From oral sex. So about 10...
The cancer was caused from it?
Yes. About 10, 15 years down the road from starting that activity, a percentage of people who have had a lot of oral sex and get HPV in their throat, and that causes them to get a throat cancer.
Wow.
That cancer is much more sensitive to radiation. So we treat those now completely differently, and they have a very different course than people who get throat cancer from smoking and drinking.
Weird. Is there any reason why different cancers react to different, like to radiation differently or chemo? Or?
There's lots of, there's lots of rationale. We don't have time to go into all of it. So yes, and there's the other realities. There's still lots to be discovered there. So we can, with many of these, we can say, yeah, we see that, we can make that observation, but that understanding of why does radiation work better there, we don't fully know that.
Right.
We might think we do. That's a good example of where, we have some hypotheses why that is the case. I'm not so sure that they're right. I think, and others aren't either. And so there's a lot of research that's being done and trying to understand, well, how does radiation actually work? And is it just that it kills cells, or does it do something else? Does it change the microenvironment in which the tumor thrives, for example, or something completely different? So those are still things that I think we're still discovering.
Wow, very interesting. You also mentioned monoclonal antibodies earlier. That's a topic that has been coming up a few times in the last few years as well. What are monoclonal antibodies?
And monoclonal antibody is a antibody that's created that will attack a certain spot and neutralize the negative impact that a cancer will have on its cells. So we see that effective with something called the PD-1 receptor. And monoclonal antibodies will block the impact of cells and allow the normal killer cells to have their effect.
I see.
I've seen, and this is amazing, and maybe it's just me. I've seen cancers, melanomas in particular, where, and that's where the PD-1 blockers do work, by the way, where I've seen where the tumor was, you can still see it. It's mostly gone. The body's actually gotten rid of that tumor. Except that it's before it got rid of it, it's spread.
Oh, I see.
So now it's in a lymph node, and that lymph node it's growing in that spot, and the body isn't able to deal with it. But you can see the original. You remove the original site, and it's either all gone or partially gone by the body's own immune system.
Oh, just by treatment with monoclonal?
No, without any treatment.
Oh,
yeah. Sure. So that just to highlight that our bodies actually are often killing cancer cells.
Yeah.
And it's only when the cancer cells escape our body's own immune surveillance does it grow and become a cancer that we see. Right. So there's so much that we don't know.
Wow. Sorry. So you're saying that a tumor could develop in that case, and then it is shrunken by the body.
Correct. And but some other cells manage to escape and spread, and those ones take over, and your body can't deal with those, and so then you have the metastatic spread. And the immune modulators that we have, the PD-1 blockers and other ones, those monoclonal antibodies, can actually help your body be more effective again in killing those cells.
That's fascinating. I didn't know that. I don't know why, but I just assumed that once a tumor had achieved escape velocity, that it was doomed to just continue growing. I didn't know that.
Yeah. No, even like if you take, say, again, a breast cancer, we now know that there's circulating tumor cells in the blood, even in the people who don't end up with spread. So they're alive, they're swimming around in your bloodstream, but it doesn't take hold. What is it that your body's doing to prevent that? I mean, we don't. There's lots of things we don't know.
That's so fascinating, and the complexity alone of the body fascinates me. Like I was reading some journal articles on nutrition because I was just interested in learning a little bit more about carbs in relation to exercise activity, and just trying to I can read the introductions and the discussions fairly well, but trying to understand all the processes that some of these articles describe, it's amazing what the body does. And just so
it's pretty amazing. I don't think there's any one human brain that can totally comprehend and hold all of that.
It's just
at least mine isn't capable.
Well, mine's not nearly capable either. And so like I mentioned earlier at the beginning, when I was prepping for this, I had to write down so many different positions that you hold. A couple that stuck out to me was you are the director of, one of them that stuck out was the director of clinical quality improvement for the Saskatchewan Health Authority. So what does that look like?
So one clinical quality improvement is really, it sounds a lot more fancy than it really is. Okay. It's about helping people do what we know we should do. The reality is, even when everybody would agree that we're supposed to manage something in a certain way, it doesn't always happen for a whole bunch of reasons. Behaviors are hard to change, and it's not. And I think an example of what might sometimes make physicians not follow guideline-directed care is I'm afraid of missing something. So then we'll do a whole bunch more things than we need to do because we're afraid of missing something. Right? Because even if you have a clinical guideline about how to manage a particular problem, it never completely covers every possibility. So you might have a disease entity. I'm trying to think of something that's simple. Management of diabetes. And you say most of the time, like maybe 80 or 90% of the time, if you do this, it's going to be the right thing to do. Another 10% of the time, you need to do something else. So the historically, the way we were trained, all of us were trained, was that I will digest the literature and the evidence and everything and apply that to the patients that see me in order to provide the best possible care. And as we were talking about just a few minutes ago, the pace of change it's exponential now. There's no individual clinician that can keep up with everything anymore. And so the idea of clinical quality improvement would be that you standardize what you can standardize, and our job then becomes a little different. It's to identify the people that don't fit that standard.
I see.
So the standard's easy to do, and then my job then becomes, okay, you don't quite fit that. Something's not quite right. You can take you off that pathway, if you will, and we're going to investigate a little bit more and make sure that we're doing the right thing for you. So it's just a change in focus on how we practice, so that we practice collectively, for the most part, in terms of creating those pathways, those standards, and then as individuals, we identify the people that need to not be on them. So I actually am one of the faculty that teaches a course for that through Health Quality Council, to try and give people the skills to do that, because it's still a relatively new way of practicing. We haven't made that shift completely, but I think it will change the way we practice at the end of the day.
And change it how?
Improve care for people. So you can say, if you have osteoarthritis, this is the way most people need to be managed, whether it's osteo or diabetes or something else, and then those standards will be maintained and kept up to date. People will be reviewing the new literature, changing those guidelines on an ongoing basis. And then as individual practitioners, our job changes a bit. It becomes more to stay on top of those guidelines and make sure they're implemented and new evidence comes into practice quickly, but also identify people that for whom those guidelines aren't working and make it context specific. For example, let's say blood pressure. We know that there's you could standardize how to manage blood pressure, but the reality is that people these days have very complex medical histories, and they might have multiple other comorbidities or other problems at the same time. And so that standard sort of mix of how you treat hypertension may not be the best for this individual in the context of their complex health problems. So then the job becomes to identify those people and customize or tailor treatment to their needs.
I imagine it's pretty difficult to work that all out.
It's probably less difficult than trying to stay on top of everything possible.
Fair enough.
Right?
Yeah.
So I think, it's difficult, but I think it is the way to work in the future. And then there's a new sort of twist on that, which is called a learning health system, where not only do you have a standard practice, but you start looking at your own results and comparing them. Because in Saskatchewan, there might be unique contextual things that say that guideline that worked well in Baltimore doesn't work in Saskatchewan. And these are the reasons why. So I think always, if we don't look at our own results, you have to run the risk of not getting the same results that they got somewhere else for just because of the context.
You mentioned that like any one physician can't keep up with all of the data coming out. Like there's just too much information. Is there's systems for physicians to try and keep themselves updated and up to date? Is it like continuing education or just like...
Yeah, there's continuing education. I don't think that's sufficient. I think it's important, but not sufficient. I think my ideal world would be like, if I look at the team that I work with in surgical oncology, we do this already. It's almost maybe because of the training that I bring into the table. Maybe it's just natural in a way. But we would say, okay, you have your interest in a certain area. Somebody else has melanoma. Somebody else has breast. And your job is to keep us current in those areas, so that not all of us has to stay abreast of every piece of information that comes in every field, and we'll just assign certain ones of us to keep the rest of the group current, and that way it's doable. It's a manageable amount.
Yeah, that makes sense. That probably helps, I would imagine, with the relationship piece you were talking about, and just keeping good relationships with the other physicians, because you have to trust them to keep the rest of you guys updated.
Yeah, it helps with the relationship piece, but relationships help develop the trust that it takes to be able to say, okay, I'm going to let you take care of that, and I'm going to let my ego take a back seat, and yes, you can be the expert in that area. And I mean, the whole other area that I'm interested in now as I move along in my career is also how do we transition to let new people take the front seat, if you will, and drive certain things, and not have to be the person who's the driver,
right?
You know, and those transitions of career, I think, are important and not well talked about in my profession.
Do you meet a lot of obstacles in that direction?
I think you get a lot of ego strokes from doing the work we do, and letting go of that and saying, no, it's a team sport as opposed to just about me.
Right.
Isn't always easy for people, and it's not that skill that is well taught sometimes.
Yeah, I imagine that it's probably one of the biggest learning curves is trying to dissolve your ego, I guess, especially if you spent so much time studying, like you've spent like so much time as a doctor, and any doctor, just developing this base of knowledge that is probably hard to sometimes let things disagree with it and try and change it.
I think, being more philosophical now than anything else, but I think that it doesn't matter there's always some place that I've had to develop and mature. I think I just managed to learn all about how to do research, and then I turn around and there's something else I have to learn how to do. So it's a never-ending game of learning and having insight as to where the learning needs to come from.
Yeah. And it seems like it's a ball that just keeps rolling for you from the way you describe it that way. You're just always trying to add in new areas to take on.
I think there's a lot to be said for introspection, and then just realizing that that we're all flawed and we do the best we can, and our best isn't always perfect, but we try anyway. And what's the next area where I can try and do something? I also, one of the things I've said to my kids is, the day that I don't think I have something to learn is probably the day I should no longer be here, because there's always some growth and some learning to be done.
I agree 100%. It's also really interesting because when you know that, when you think that way, it's really difficult when you encounter someone that thinks they have approached knowing everything and that they don't need to learn anymore.
Life will help them understand.
Yeah, well, you'd hope so. Some people are pretty damn stubborn about it. But no, that's great. And yeah. What is the next thing that you're trying to know about and pursue?
Yeah, that's a good question. I think that there's multiple little things that I'm trying to do. But right now I'm in the process of transitioning to this sort of research and supporting my profession, actually, in terms of understanding how to work differently. And those are cultural changes. And cultural changes are slower than what I'm a surgeon, I have a problem, I diagnose it, I fix it, and it's done. Just learning to be patient, I think, is probably one of the things that's at the forefront for me, is to learn a little bit more patience and breathe and understand that cultural changes take time.
Is that the cultural change you're trying to look at, patience?
That and maybe incorporating some of the wisdom that comes from Indigenous communities, and whether I'll just do that personally, or if we can actually infuse that into our system. When we talk about indigenizing, I sometimes get frustrated with the idea, because it's almost feels to me like people are talking more about checking off a tick box. Because I think to really learn something from another culture, you have to come at it from the perspective of, I have something to learn, and that they have something to offer. And if you don't, you're not going to learn anything. and I don't know that we're there yet. I think that Indigenous worldviews have a lot to teach us. We just have to learn to listen.
And do you think it's going to take quite a while, or do you think you'll be able to speed it up a little bit? And
that I don't think it's going to be quick. I think those are slow processes.
Yeah.
I don't have that kind of skill set to speed up something like that.
That's fair. Yeah. There is. Yeah. Do you get frustration from anybody else in medicine or in the industry from trying to meld those two worldviews?
No, I think sometimes when you were talking specifically about Indigenous worldviews, I just don't think that people always understand. I don't get a sense of frustration. It's sort of like, sure, you can do that if you want, but I'm busy doing my thing,
right.
Which is fair. I mean, one of the things that bothers me the most is when somebody says, "Well, I think this needs to happen," and I'm going to do this about it. It's like, this needs to happen and you have to do it. Like it doesn't work that way. You know? There's lots of issues, big issues, wicked issues going on in the world right now. Climate change being one, and I'm totally supportive of climate change, but I don't spend a lot of my energy on that, not because it's not important, but because other people are doing that. And so I spend my energy where I do, because I only have so many energy points to give in
Yeah,
any
of
given
course.
year. So I support and care about the environment, and I trust the people that are leading that work and to follow. So there's times when I need to be a follower, and other times where I can be a leader.
Yeah, well, I think that's really important because, like you said, if you try to do all of it, you're spread too thin, and then you're not helping out nearly as much as you could in any of the areas. So, and with this integration between Indigenous cultures and the system we have now, is it looking more at, like you said, just the relationship aspect, or is it trying to integrate more treatments?
Yeah, so I have done a fair bit of exploring in my own mind around traditional Indigenous health and traditional healing. I think I can say with confidence that my Indigenous colleagues would hone in on the fact that Indigenous healing and Indigenous health is more holistic.
Mm-hmm.
We tend to separate them and say there's the mechanistic side of healing, and then there's the other side of healing. And not that we don't think it's important, but we would say that's the responsibility of your social network, and et cetera, et cetera, et cetera. And Indigenous communities would say, no, they're one and the same. They belong together. So I think coming back to where we have a more holistic approach to healing overall would be value added for us. That doesn't mean that I have to necessarily do what you would want to do, and vice versa, but that the way our approach would be to healing is more than just what medicine am I going to take? Am I going to have an operation?
Right.
Or not? So I think in that sense, there's a lot to be learned. There's also, I think, again, I don't want to generalize too much. I want to be careful. But I think many Indigenous patients, when I speak to them, their goals of care are bigger than just, am I going to be cured of this cancer?
Right.
When people die, I'm going to die. You're going to die, right? So someday I will get whatever, whether it's heart disease or a cancer, and I will die from it. Mm-hmm. Death itself doesn't scare me. And so my goals of treatment, if I were to get something, would be, if I can, I'd like to be cured, of course, but I also want to make sure that my relationships with my family and my friends are strong. And I actually, knowing because of the work I do, I want to do that even before I get those kinds of things. And right. I would say that is, when I speak with Indigenous elders, that focus on what is important in life, what is it that you're trying to get, is more upfront and center than it necessarily is with Western systems. So,
yeah,
I don't know if that made any sense. Or
no,
it
it
was
made
just
perfect sense.
Completely rambling there.
No, that's great. Well, it is true. I believe that that type of outlook does tend to produce better overall health outcomes. Is it not? Like having better connections to your family, your community.
There's a strong association between those two.
Yeah.
It's a lot harder to have cause and effect sort of evidence, but there's lots of association in that regard. Yes.
Why would you think that that relationship is found?
Say that again.
So why would you think that there's an
association
between?
But because first of all, we don't understand all the mechanisms that cause ill health. But my health is more than just whether my body's functioning well or not. It's connected to all the other things. But I think there's also good evidence. It's not, again, cause and effect is difficult, but there's good evidence that if you're living a good, healthy life with good relationships, you probably eat better. You drink less. You maybe don't smoke. You exercise. All of those things that are very clearly associated with better health outcomes.
So it's not necessarily just that having a good family and a good life makes you healthier. It's that you're more likely to engage in healthier behaviors because of.
Yeah, so there's a whole body of evidence that goes around the social determinants of health, so that your health and well-being is bigger than just diabetes or no diabetes. It's got to do with a host of things like your socioeconomic status education, housing, things that are not what we normally think of as health, but
Right.
they definitely are associated with better health. We could talk for days about social determinants of health.
Well, let's do it. Yeah.
And I
Let's
think
go on.
culture is one of those social determinants of health. So that's from my bias, that having a strong sense of who you are and where you come from is associated with better health. The mechanisms by which that happens are not as well understood. They're starting to be understood, but the associations are pretty strong.
What is your theory in that regard?
I think it might have to do with stress hormones, with all kinds of things like that. If you don't have good housing, or you have food insecurity and you're not sure where your next meal is coming from, that adds a lot of stress in your life. And over time, those hormones that are designed to help you be, run away when you're in trouble, can cause adverse effects.
Right.
So I think there's a lot of those kinds of mechanistic things that are interesting to researchers for sure. Will become more and more clear. But I think there's strong evidence that social determinants of health are important.
If you had to say there was one that in your mind was the biggest determinant the biggest social determinant of health, where would you look?
I think the one that surfaces the most common is socioeconomic status. Whether it's the most important or not, I'm not certain, but it's the one that's most talked about.
Right.
Comes to the surface probably the most. But I think early childhood development's a really important one, and education. So if people don't enter into life with a good start, that affects their entire life. So I if you wanted to compete between those ones, might be more of those, that education, early childhood development. But I think there's a lot of overlap. Like if you look at the standard sort of social determinants of health that are talked about, there's a lot of them that overlap. I think a lot of times there's not just one social determinant of health that impacts people. There's a whole host of them.
Yeah.
Yeah.
They're so connected.
Yeah.
So for socioeconomic status, might it just be access to care, or
that's just the beginning. I mean, it impacts your ability to eat healthy. I mean, if you think about it, if you're up north, it's alcohol is subsidized, food is not.
Right.
So there's perverse incentives that we have, right? And so it's hard to, if you feel unsafe whether you're going to have a decent meal or not, or if it's cheaper to eat fast food and to make a good meal, and maybe it's not cheaper, but you don't have the skill sets to do that. I mean, they just all add together and create an environment that causes you to have a poorer outcome from a health perspective. It's one of the things. Sorry, I'm gonna.
No, keep going.
My head's going now. Like when I think about, one of my colleagues recently asked me if to help him on a project, and I haven't had a chance to talk to him. We have a meeting coming, where they're looking at a particular kind of cancer and the fact that it gets diagnosed late in northern Saskatchewan, and what can we do to improve that? And the work I've done to date says, well, you can try and focus on that one cancer, but that's not the way the people see their health. They just see, I'm unwell, I need somebody to look after me. So they need to trust that the system will look after them, and they don't trust that right now. So just focusing on one particular, maybe seldom diagnosed problem doesn't fix the system which cares for people's health in the north. It's way more complex than that.
Yeah.
Or even you look at one of my master's students right now is just finishing, I had to nudge her quite a bit, but did quite an in-depth analysis of why children in the north have dental caries to the extent they do. And they do. It's
Dental what, sorry?
Dental, bad teeth.
Oh, okay.
And so these children are often flown down to Saskatoon, where they have general anesthetic and have their teeth pulled. And it's not a simple thing. I mean, it's a complex, multi-layered problem that includes colonization and lack of trust with communities and with the healthcare system. And yeah, it's not as simple as it looks on the surface.
Yeah. Well, I know that lack of trust was a big one in the U.S. for the African American community in the last few years, because
Still is.
Yeah. Well, they've got a long history of not trusting the healthcare system, and in a lot of ways, rightfully so. And so people look at things and say, like, "Oh, they're not doing this, or they're not getting vaccinated. Like, why aren't they doing this?" And it's like, well, a lot of them they're not very fond of going to the doctor to be treated, because it's not, throughout history, it's not always been exactly the way you would expect to be treated.
Absolutely.
So yeah.
And it's easy to look south of the border and see the issues that they have there, but trust me, we have similar ones here.
Yeah, and unfortunately, I'm not as aware of them, which is why I gave that example. But that's a big issue too. Is that I don't know if this is true, but I believe I remember learning in the last few years that, like, I grew up, and through my entire education career, I've learned about Indigenous history in Saskatchewan. But I heard one time that that's not the case in other provinces, is that they're not always taught about, like, Indigenous studies and social studies are not as, they're not taught about as much. And so I didn't know that, but I think that a lot of Canadians just don't know about a lot of these, the unfortunate history about a lot of people here, a lot of Indigenous communities, and why they might have the skepticisms they do, and might not want to, are not fond of the healthcare system, or this and that.
Yeah, and I mean, that's just the tip of the iceberg. I think we tend to, even when people try, we tend to have, and I did too. So when I say people, I'm including myself. We tend to have an approach where we think of, they would call it a pan-Indigenous approach. So all Indigenous people are the same, and that's not true.
Right.
I mean, there's Métis, there's different First Nations communities, and each one has their own culture and their own vibrant strengths, and we tend to lump them all together, and it doesn't create the nuanced understanding that I think that those communities would want from Canadians.
Mm-hmm. Yeah, well, I imagine it's incredibly frustrating to just be called the same as everybody else, when in your mind, and not even in your mind, like in reality, that you're different. You're a different nation. You're a different people with your own cultures and customs and language, and to be treated that like, oh, you're just the same as these people. I imagine that in itself would contribute to negative health outcomes. Just being frustrated by that, like you're talking about. If your stress hormones are up all the time just from social angst, that probably doesn't help much at all. So
yeah, you'll have to interview somebody from Indigenous communities next to understand where they're coming from, because I can't speak for them.
No, that's fair. My next guest actually is my previous guest works in he tries to help out with the youth neighborhood. I'm gonna mess up the name, but he works at a co-op, and he's an Indigenous man that's doing his best to give back, and he talked a lot about those frustrations. And so yeah, I can't imagine. I'm not in their shoes, right? So it's hard, and I try my best to keep my eyes open and take as many perspectives as I can, and remember that my experience is not anybody else's, and that it's important to see that and know that even though we're all people, but we're all unique in that we're all people. That everybody's looking at the world through different eyes. Mm-hmm. And so it's very, very important, and it's very comforting to hear the stuff that you've been talking about, how you're looking at how we can learn from different perspectives and integrate them and communicate better and develop better relationships with people and communities. And it's very important. And I think that thankfully today in the modern world, there's a lot more effort being put in that direction, which is very good to see. Makes me happy, at least. So
yeah, I think we'll just slowly move forward,
Mm-hmm. Yeah, one step at a time. That's the way it goes. You said that educating came after practicing, and that you said that wasn't something you really planned on getting into as much.
Mm-hmm.
And so now you're a professor in the Department of Surgery as well.
I have a joint appointment in
Okay.
surgery and community health epidemiology.
Mm-hmm. And so what does teaching look like in those areas?
So for years already, I have helped teach and train surgeons, general surgeons in particular, and undergraduate trainees, and that's just helping them on multiple levels. Like surgical training is, I think, more like a traditional apprenticeship in some ways than you can't just learn surgery by reading a book.
Yeah.
So you have to. It's a combination of book knowledge as well as technical skill, and so I've been doing that for 30 years now. It's really quite fun because you work with a team of people or a group of trainees over 5 years. It's 5 years generally to learn to become a general surgeon after your medical training.
Wow.
And then another, generally nowadays, 2 years in a subspecialty, and sometimes even longer. So it's really quite rewarding to watch these people become mature surgeons over time.
Yeah, I imagine that'd be incredible. In 5 years, just like going from not having practiced any surgery and slowly practicing more and more, or
Yeah.
yeah.
And so by the end, especially after a subspecialty training, most people are ready to start learning. So the learning curve is still quite steep when you go into practice, and so there's ongoing mentorship that happens when people come into practice as well. So that's been very rewarding. I also have mentored a number of medical students over the years, where you just sort of answer the questions and help them be curious and watch them grow. And a number of those now have moved on and are out in practice. And then more recently, I have graduate students. So I have quite a few graduate students that are trained to do research, and that's also quite rewarding, as well as the clinical quality improvement course that we teach. We're on to our, I think, 5th or 6th cohort of about 20 each time.
Oh, wow.
So that's been very rewarding.
Yeah. And like I said before, or like you said before, it kind of just happened educating? Yeah.
So I have very little formal training in educating. And when I did my PhD, I did some training then. And then when we were doing the clinical quality improvement course and creating it, we designed it after a program that was in Utah that was very well recognized. I was fortunate to get some fancy education sort of theory at that point and learn a little bit more about how to teach teachers or how to teach adults in particular. Adult learning is kind of much more enjoyable. Yeah. Because it's really, they have to want to learn, right? So when somebody wants to learn something, they go after it, and they're motivated and they learn. Yeah, it's very fun to work with people who want to learn.
Well, seeing somebody else's passion for something is very, very energizing too. You see somebody excited and eager.
It's like lighting a brush fire. Right? You just have to light it.
Wow. And so, how much time does that take up? You've got lots of appointments and lots of different positions and stuff that you're working on. How do you fit it all in? Especially if you're like when you're teaching, you got to be there and engaged. How do you keep it all straight, I guess?
I have a lot of support. I have a lot of support from home. I have a lot of support from a team of people that provide that support. Like if you think about the Health Quality Council, the design of that was done by people with expertise in Health Quality Council. So yeah, I again, even teaching I see as a team sport. You know, there's a team of people that bring it together and pull it off, and that's the way it should be.
Is there anything that you try and distill in everybody that comes across you, in particular in teaching? Anything that
just to maintain curiosity. I'm at a stage in my career now where I really don't have a lot of patience for a system that requires grades. Like I'd much rather that somebody's coming to the table because they want to learn. And I understand the necessity of still having a standard and all of that. Don't get me wrong, but my ideal is just to instill that passion for learning. That it's you're never done. That you're constantly learning. And I re-met one of my surgical residents the other day. He came down, and we put on a symposium for breast cancer for one of those kind of challenging areas of breast cancer called triple negative breast cancer. Sort of a subset of about 10% of women who historically have had very poor outcomes and are now starting to do better because of some of these targeted therapies and whatnot.
And sorry, what is triple negative?
They're estrogen receptor negative, progesterone receptor negative, and HER2 negative. So that subgroup of women, under the microscope, it still looks like breast cancer, but we know from these tumor markers that they will do poorly. They're often younger, and some of these new things we were talking about earlier are starting to emerge as being giving good results, and so that's was the focus of the symposium that we put on. And one of my residents from years ago came back to visit along with his family. Dr. Datani is a family doctor in town that I've worked with over the years as somebody who referred me patients. But I got to know him because his wife passed from triple negative breast cancer, and he made a research donation to the university that I now manage. And so Dr. Datani's son was our resident. He's now a surgeon in the States. And I got to eat lunch with him, and his enthusiasm for learning and for integrating new things into his practice was so contagious. It was so delightful. Just as like he went on and on. He was just like a little child nattering away about all the things he's been learning and integrating into his practice. And he now does his colon resections. Traditionally, when I was still doing colon resections, people would stay in hospital a week. He does them all day surgery, and he's doing them with robots helping him minimally not use big incisions, but just small little incisions. And so the first transition in care was to laparoscopic surgery, where you just use tiny little incisions, and now they're moving to doing colonic resection, with robot. And he's just so excited to be able to learn these things and integrate them into his practice. And I had a couple hours just listening to him being excited about learning. And it was very fun.
Yeah, those are the best conversations. You just listen to somebody and just go on and on and on about the things they love and they're trying to learn. I love it. Yeah, it's one of the reasons I'm doing this. Do you have that experience a lot? You got a lot of students that are just...
I find that sometimes we get in our own way, in that life just gets in the way or whatever. But at the core, I think most of my colleagues, yes, they love to learn. That's why they're there. Yeah, they love to provide care, but they also love to learn. When you said at the beginning, I'm going to challenge you now. I'm going to come back to the beginning, and you said that I think it was before we started, that you see yourself as a consumer of research rather than a researcher. That was my view of life for the better part of my career. And now I think we all have the capacity to be involved in research. In the sense of research, it's just an acknowledgement that we don't know everything. And so whether it's asking the questions, making observations, noting this isn't quite the way I was told that it worked, and maybe there's something else going on, that's all part of the research piece. So I think most of us are actually at the core researchers. We just don't know it yet.
That's very eye-opening. Thank you. I've never thought about it that way. There's something so fascinating too about just trying to find answers and doing that and trying to learn and that's why I'm so fascinated by people like yourself that go out and try and do that and are trying to educate themselves and trying to gain this wealth of knowledge and going into the research and the perspectives that I've learned just from our conversation today, or I guess for me that kind of feels like my research for myself is just gaining that knowledge and trying to understand why somebody else is curating, trying to educate themselves further and further and improve their field and themselves. And, so I guess you could say that, yeah, I'm at my core a researcher as well.
You're asking questions. You're not happy just to sit and accept that it is the way it is. You want to understand why.
Yeah, you're definitely right that way. I do. I guess just like yourself, I'm very curious and always trying to learn more. And like you said, ask the questions.
That's at the root of research, is that curiosity.
Maybe I shouldn't have given it up so quickly.
Who says you have?
That's true. That's true. You could always go back, and I don't know. I really like this medium as well, and I think it allows me to do that well. It's just not publishing papers.
I think that we could go on again for another day or two. I think that publishing papers is not necessarily should be the focus of research. Research, I think that's what drives academia sometimes, and it's what drives promotion and tenure in academia. But research, I don't think, is just about publishing papers. As a matter of fact, I think publishing papers is just one way of transferring the learnings that you've had from research. And so I think that research is much bigger than publishing papers. It's about understanding a phenomena. And research is not just the work that I do. It's the work that I do combined with the work that 100 or 1,000 other people do. That was one of the things about the pandemic that I found positive, and that I find, like the research network that we're forming around long COVID, there's so much to be learned. I don't understand it all, and there are other people that have better insights into aspects of that than I ever will, and there's things that I have to bring to the table, and it's only when we work together that collectively we come up with an understanding. And at the end of the day, a lot of that understanding is going to come from the people that are suffering with that disease in the first place. They don't. We just help tell that story and help to understand it. And we have some tools at our disposal that help us get there. But the tools we use today are different. Like the research tools are different than they were 20 years ago. They're not always the same. That's also evolving, right? So I just think it's exciting just to be a part of that curiosity, understanding, and learning.
I think so too. Well, like you said, I guess, yeah, it's not only about publishing the papers, and you say that the people that are suffering from these conditions they're the first person perspective of the condition. The researcher or the physician or whoever's looking is the observer, and gaining the knowledge is the most important part, and trying to be able to apply it and just gain understandings to try and make the world a better place, right? And I think for myself personally, I guess this research that I'm doing is the reason I like having these conversations and learning about people and trying to just gain information from people like yourself is so that I can learn how to operate better in the world myself. And if I can help somebody out, then I would love to do that. And that's why I record the conversations, is so that if anybody else can gain anything from the questions I've asked you today and the conversations we've had, then even if it's just one person, then that's important, right? So
I would argue you have a very curious mind that maybe was a little constrained by the structures of the university.
Yeah, I would tend to agree with you. I think I wasn't thrilled with the way the undergraduate system was set up, but I did get a net gain for sure. I would say that I would never say that I wouldn't go back. So
it'd be very interesting to see where you are 10 or 20 years down the road. I may not be here to see it, but it'd be very interesting to see your journey.
Well, thank you. I'm very interested to see it as well. I get really excited when I think 10 or 20 years out. Because I was having a conversation with another professor. It would have been last year now, and we were talking about the fact that it seems like, from just like reading and the conversations I've had here, it seems like 10 years is about where you start to begin like really deeply learning about things. It seems like it takes 10 years for people to really become like really, really deep in their subject. And at that point is when the learning starts to unfold itself even more so. I don't know why I came up with that number, but it seems like a decade is really where the groundwork is done so that you can just get even further into it afterwards.
Yeah, I think we're always learning. We don't live long enough to continue building, but it's not necessarily linear. I think we sometimes think very linear. It's very it goes where it's going to go.
Mm-hmm. Yeah, I'd agree. I wanted to ask you about Dr. Cherkov recommended me your name, and he said that the two of you co-teach a course on critical realism.
Mm-hmm.
But what is critical realism? So I didn't want to look into it too much because I wanted to hear you explain it. So,
I think it's a lot less complex than my colleague Dr. Cherkov sometimes likes to make it. It is really what we were talking about, where I'm trying to understand a phenomena, whatever that phenomena is. And I accept that I will never fully understand it, and that what I think I know today will probably be different tomorrow. And it's about trying to understand what are the actual mechanisms underneath something. And I think it's easy when you're looking at more biological phenomena. So what causes a dental tooth cavity, right? The mechanisms behind that are fairly well, as it turns out, I didn't know this before, but they're fairly well described, and we know what causes them. But then what are the social mechanisms that go into why one area of Saskatchewan has a higher incidence of tooth decay than another? That's much more complex. And the social world is very complex. And so when you try and, I think psychology and sociology sometimes, when you're trying to apply sort of research methods that are generally used by the biological side of the world, it's hard to capture. It's hard to put things in a closed system when we have, in fact, social systems are open systems, and there's lots of things that are affecting them, and those sort of research tools are sometimes they get at pieces of it rather than the whole. And that's okay. That's how we came about understanding about diabetes in some sense. But it's about trying to understand the underlying mechanisms. It's as simple as that, and that's what science is about. That's what research is about. And having the humility to know, to be able to say, yeah, I see there's an association here, but I don't know if that's always working. Why does it work sometimes and not others? All of the complexity of what is the world, and how in my case, how the body works and how health systems work. And it's not. I think it's about trying to understand that complexity in its fullness as much as humanly possible, knowing that it's never perfect.
Right. Yeah. Dr. Cherkov talked a lot about like the essence and trying to find the essence of things.
But that's that. The essence is, how does it work? Like what are the actual functional parts of that? Like what makes it work? It's not just this intervention that I'm using works or doesn't work, but how does it work? And why does it not work in northern Saskatchewan but it works in southern Saskatchewan? Why is it that it works in Saskatoon but not Regina? That understanding the complexity.
And how long have you been teaching that course for?
We've taught it 3 or 4 times.
Okay. Well.
Yeah. And I have colleagues around the world. I've taught similar courses in Australia, and
wow,
it's a smallish community that's still evolving, and I think that is at the core what research is. I don't think it's a reinvention. It's more a philosophical approach than anything else. It's about, we're trying to actually understand a phenomena, whatever that phenomena is. And it can be biological, it can be social, it can be at many different levels, but especially when you're looking at psychological and social phenomena, they're very complex.
Mm-hmm.
Health systems are incredibly complex.
Mm-hmm.
You know.
Yeah, well, I imagine it takes a bigger brain than mine to try and understand it all. And you speak about philosophy in that area as well. Do you go very deep into that much and trying to take like a philosophical route into understanding those things in your research and practice, or?
Yeah, absolutely. I think most of my research comes at it from that. The philosophical approach when I'm saying that, what I'm trying to say is, like, I believe there is a reality.
Mm-hmm.
I don't think that, like, I think that tree falls in the forest whether I see it fall or not.
Mm-hmm.
I think that there is a reality, but my human brain is not always capable of understanding everything.
Mm-hmm.
And even when I mean, you just think about the things even in your lifetime that are starting to blow your brain apart, like quantum physics, you know, or I don't know if you know anything about epigenetics. That's one that just, like, I thought I understood genetics and then this came up, you know.
That's a fascinating topic.
Those are all fascinating topics because you think you know it and then you realize you don't, you know, or you only know a piece of it. And I think having the humility to realize that philosophically, yeah, there is a reality out there, but we're probably only capturing a part of it. Even when it seems solid, like genetics seemed solid and physics seemed solid, and then all of a sudden there's these new ideas that somebody's brought in. It's like a paradigm shift, you know. And you say, oh my, I only knew part of it.
Do you think there's anything deeper to the reality and looking at the reasons why things happen? You believe that there's not that it's necessarily spirituality or religious, it could be anything, but do you think there is?
It's a Sunday, so you're getting into the spiritual side.
Yeah.
I think that when we move into the space of spirituality, it's difficult to prove that.
Mm-hmm.
It's much more belief based then at that point. And so I'm going to share my belief. Yes, I believe that spirituality is real, and I believe it's important, and it impacts all kinds of things. Do I have an easy way of proving that? No. And I'm okay with that.
I was actually having a conversation about that before you arrived, about how there are some people tend to get upset with the idea that there are religious truths and empirical truths, and I thought that the issue might be that truth is only just the best word to try and make agreement between two things that are not necessarily the same. And so I thought that the idea I had this morning was that maybe when people are looking at empirical truths and getting upset with this idea of religious truths or things in spirituality that can be helpful, is because they're trying to make the word truth fit religion or spirituality in a way that means empirically true. But it could just be that there are religious truths or spiritual truths that are just things that are common, or just lessons that are very, very important to be taken, that can help people in their lives, and help people be better in the world and help better the world. Not that they're necessarily provably true, but they're very, very useful lessons. And
I think there's interactions between what is empirically visible and provable and our belief systems.
Mm-hmm.
So I mean, the challenge with when you move into spirituality, from my perspective, is spirituality is often more about belief than what is empirical, and those spiritual underpinnings can definitely help inform your understanding of reality in the world, but it's not a thing that you can prove or disprove.
Mm-hmm. Yeah.
But I know if you swing back to indigenous worldviews, their belief is that spirituality is a part of the empirical as well, and they're hard to disconnect.
Right. Yeah. I think an important thing to think about when you're looking at spirituality as well is whether it's helping, like, first of all, you, and then you as a person of the world. But like, I I think it's naive for people to be dismissive about spirituality and religion and spirituality and religion's teachings, just because it's in that category of spirituality and religion. Like, if these things are helping people to be better and improve their lives and improve the lives of other people and the world, then why be dismissive about them? You know? So.
I think, I mean, again, we could go on forever, but I think the challenge is that that we've seen a lot of harm that has come from, especially institutions, and that colors people's perspectives around spirituality and religion. And I think that's unfortunate, because I think that happens when I have a belief and I want to impose my belief on you, as opposed to I have a belief and my belief helps me live my life, my best life.
Mm-hmm.
Those are two different things.
Yeah. Well, yeah, I'd venture to say that the imposing part is the problem, and I think that's what you're getting at as well. Yeah. Do you mind if I ask if we can get a little bit more specific about your spiritual beliefs? If you don't want to cover it, that's completely fine.
I personally, I grew up in a Christian background.
Mm-hmm.
I went overseas as under the auspices of a religious organization. I came to, over time, become much more skeptical about the institution of church, but I still believe that there is. I don't believe there's a higher power as such, but I think there's something that connects us. I think there's something about spirit that is important.
Yeah.
I don't know that I know what it is, but I do. I'm not dismissive of it.
There's something very interesting about the mysticism about it as well. That's very intriguing. And I think it's hard to be dismissive about those type of things. Just to say that no, it doesn't exist. There's no spirituality, or there's no other level to reality, or there's no spirit and there's no soul. I think I don't know. Obviously, it's just my opinion, but I think I would tend to lean more towards agreeing with you that it's just because you can't prove it doesn't mean that you need to completely ignore it or disagree with it. And it doesn't have to be something that's completely laid out for you by somebody else. It can be an entirely personal journey.
Mm-hmm.
So, do you find it informs and complements your work well?
I like to think that it keeps me humble. Because I don't fret over understanding everything. I try my best, but I'm not. Spirit is something that I don't have empirical evidence or proof for, and I've learned to just be okay with that.
Does it give you comfort not knowing, or do you still try to, even though you're okay with it, do you still try to discover?
No, I don't spend a lot of time there.
No, that's fair enough. When about did you change this outlook on it from more away from?
I had some not positive experiences with the institution of church. So
that's fair enough. It's definitely an interesting one. I was very religious for a long time. Been a part of a few different churches, and very similar experience to yours. I just moved away from it. I don't know. Just the institution itself seemed a little bit odd to me, but like I said, I would still agree with you. I find myself to be quite interested in spirituality and trying to observe the world from that lens, and I think it goes back into perspective taking as well. I'm trying to look at things not only just from a material lens, and not necessarily to gather answers or reasons, but just to see if there is something else that can be informative or helpful, or it's hard to describe.
It is hard, isn't it?
Yeah.
I agree.
You said you don't think about it too much anymore.
it's not something I worry about.
Mm.
Put it that way.
Fair enough. Is there anything we haven't covered that you're deeply passionate about?
I'm pretty passionate about lots of things, but I think you did a good job.
All right. Well, I think that's about it then. That was a very, very great conversation. Gary, thank you very much.
Thank you.
I feel very informed, and I learned quite a bit today. And no, that went really well, and thank you for coming on.
Thank you for having me.